Computer here at Douglas College. Just want to say a very warm welcome to people. I know that it's extremely warm across the province of British Columbia, and perhaps where you are in the country that you're warm as well. So stay cool. We usually tell you to stay warm, but we're telling you to stay cool and look after your little self. Really great to see you here with us this morning. So just to make sure that you're in the right room and right webinar, this is the Psychosocial Rehabilitation British Columbia Advanced Practice team. I know that many of you see us, next slide please Jen, often on these webinars. Thanks so much, Jen. So you'll know that our founding member is Dr. John Higginbottom. Very grateful to him for really conceptualizing this educational platform for all of us. So big thanks to John, myself, Regina. You'll see our great team, Jen and Manny, who are always in the background and really make things work super smoothly. So we're very grateful to both Jen and Manny, and to Jordan as well, who's really the technical person who put this all together at the beginning. So thank you as well. So I'm just trying to advance that next slide, Jen. Thank you. And you know that we're funded by the Ministry of Health that provides leadership and guidance to mental health field to develop and put effective evidence-based psychosocial rehabilitation into practice. We are so grateful to people who say yes when we ask them, please would you do a webinar for us, because you'll remember that really there's not a lot of money involved in this, so people do this out of the kindness of their heart. So we're really grateful to people for presenting. And also we're just a little reminder, we will give you an evaluation, so please click on that link and tell us how we're doing, if we're any good or rotten. So please, we need to hear from you. So this just slide speaks to really more specifically what BC Advanced Practice, our purpose is, and we're very grateful as well to Douglas College, who provided us some extra funding this year to allow us to continue our work for this next year. So big shout out to Douglas College as well. And next slide please, Jen. As well as Douglas College people, we wish to acknowledge the Kikwa First Nations, as well as all Coast Salish peoples on whose traditional and unceded territory we live, learn, play, and work. And we say that because we are really publishing from that space. So just want to acknowledge that. And we did mention the evaluation, so just really helps us stay on track, make sure we're providing you the right kinds of information that you need. So we honestly look at all that information, so thank you. And next slide please, Jeff. Just a little bit of a heads up, just to save the date. So we have an incredible lineup for you in October. So there's a 2-day conferences coming October 28th, I believe. Jen might just help me, because sometimes my old memory is not the best. But one day with Tom Hay, who you will likely know as being an occupational therapist for several decades here in the city in Vancouver, very experienced and has done incredible education around mindfulness, so himself. And also we're very proud to bring to you a focus on cognitive remediation with Dr. Christopher Bowie, so from Queen's University. So we look forward to signing you up for that. So that will be here at Douglas College, and please stay tuned for additional details. And next slide please, Jen. We do want to ask for your help as well around Pathway 4. So this refers to the certification process for PSR Canada. So just to let you know that our new Pathway 4 is up on our website, which you'll see, psrcanada.com, Pathway 4. So please check this out and just let us know. So it provides eligibility for people with lived experience. So we really want to make sure that we get this wording right and make sure that it makes sense to people. So we look forward very much to getting your feedback before we consolidate that. So it's in draft form right now, so we'd like to hear a little bit more. And then with our last slide, Jen, it is my great pleasure to introduce to you our speaker for today. So you'll see him in the camera just in front of you there, but he will speak to us about moving from client-centered care to client-centered systems. So we're very grateful to have Mr. Leader with us today, who I think just brings that focus to transformational system change. So he is a registered psychologist and social worker, and spent 28 years working as a transformational leader in health services, and has also been teaching at the Faculty of Science at St. Mary's University for the same 28 years, and that's in Halifax, for those of you like myself who is, where is St. Mary's University? So Halifax, so very international university in Halifax. So among other roles, Todd currently works with the Canadian Cancer Society as VP of supporting programs for Atlantic Canada, and also works as a consultant, speaker, and facilitator to help lead client-centered system improvements. Using his 2006 book, It Is Not About Us, The Secret to Transformation in the Mental Health and Addiction System of Canada. And as many of you know, this work is just so incredibly aligned with the Mental Health Commission's framework document, the point 6 in particular, transformational change. So really grateful to have Todd with us today, and just want to say shout out to Jen, who met Todd at a peer conference recently and asked for his support. So very grateful to both of you for making this happen for us today. So Todd, I'm just going to turn off my camera and my mic and say over to you.
Okay. All right. Well, hi folks. Thanks for joining in. I'm going to start just by introducing the basic concept that my book was about. And just one correction, Regina, when you're reading that, you noted, you said 2006 for the book, and it's 2016. So that's a relatively important point that I just want to correct. So it's still hot off the shelves.
I had a moment. Thank you. I appreciate it.
It's all right. So, you know, when I started thinking about writing a book about this concept, about client-centered systems, I came from a diverse background in healthcare, where I had been in leadership positions in primary healthcare, chronic disease management, health promotion, addictions, mental health. I've done a variety of things, and what my observation is that most of the system, actually, in most areas, needs this kind of change. So I considered writing the book about the whole health system generally, but ended up concluding that I really wanted to write it about mental health and addiction specifically, because my belief is that the people who we serve in these fields actually have less of a voice than most people in healthcare. The very nature of the difficulties and challenges that people are seeking support for in this field directly inhibits their ability to advocate for themselves, to feel assertive or confident enough to find the words, to have the clarity of thinking. You know, I have arthritis in my knees. If I want to advocate for better services for my arthritis in my knees don't stop me from doing that. And that's a key point for this field. Anyway, so I've decided to specialize the book when I wrote it, just to give our clients more of a voice. And so as I've listened these days to a lot of the public rhetoric and a lot of the campaigns that are out there, there's been a lot of push toward us adding more resources to the system, more money to the system. And I just want to be clear and precise in what I'm saying here, that I would never argue that we don't need more money, because across this country there is no question we have serious pockets of shortage. But it's also really important for us to know that if we just take that money and add more of what we have now, nothing changes. We end up simply giving ourselves the opportunity to dig ourselves into a hole again. What we need is fundamental change, not just more of what we do now. If you listen to the public, you listen to what the public are crying for across this country, watch the media, you will find some common kinds of themes about what the concerns are, what the complaints are, because of course you do hear lots of complaints about any programs. But the nature of those complaints, they're not about the clinical kind of care or support that they get. They're about the administrative structures and processes. They're about the systems. They're about the hoops that we make people jump through. And that's a fundamental issue here, because unless we're addressing that, we're not going to change the experience of the clients. And that needs to become our target, the experience of the clients, not necessarily the effectiveness of our treatments. You know, we know what the evidence says and what it supports. We know the kinds of psychotherapy that work. We know the value of peer support. We know those things. We have lots of very competent, passionate and compassionate people providing those services, but many of them are working within systems that frustrate their desire to provide truly client-centered services. And so, many of you may be working in those systems where you would love the flexibility to adapt more of what you do to the needs of individual clients as their differences and uniqueness present themselves to you. But you're stuck having to abide by policies and procedures and restrictions that for the most part serve the needs of the system and protecting the system. So we're going to get to that in a few minutes. But that's the kind of shift we need to make. And it's a qualitative shift, not a quantitative shift. And so we can add more money, that's fine, but what are we going to do with it? Are we going to do the same, or are we going to do something different? So if we're going to start talking about client-centered service, client-centered systems, the essential piece of this is for us to understand these questions that we take for granted. We don't often talk about who is the client. It's a question, in fact, that I've almost never heard asked, except when in meetings around liability and risk management. I've heard lots of people ask the question, well, when does somebody become a client? What is that legal point at which we have a duty of care to somebody? And so I hear it in that context, but not really in a broader context. When I think about this, I make a clear distinction between public service and a private practice. In a private practice, the client is the person who walks in the door and pays or provides insurance or something, the person who walks in the door to contract you or hire you to provide service. That's pretty clean and clear cut. Everybody else in the population is not your client. You have no obligation to them whatsoever. So it's nice and black and white. But in a public service, is it different? Well, technically speaking, a public service is funded by tax dollars to serve the public. Therefore, all members of the public are, in fact, the client. As a population, they are the client. Our services, however, across the country, are not designed to serve that whole population. They're not designed to serve that whole client group. They're designed to serve only the clients who have become ill enough to qualify for services. If you look at the media clippings, what you will find is very often, in very many places, people complaining, concerned essentially about the fact that someone might take a family member to an emergency department, to a hospital, and get turned away after an assessment, even though the family knows that this person's threat of suicide is real. And so we have those kinds of cases happening. Now, I'm not suggesting at all that every single person who ever comes to an emergency department should be admitted. There are absolutely clinical decisions there. But what's really happening, this is the part I want to get at, what's really happening is that the system is deciding that someone is not ill enough to qualify for that particular kind of service. And so let's take it to an outpatient level, community-based kind of level. Somebody contacts the service for care or support of some sort. Well, how do we decide when they get an appointment? Well, in lots of cases, there is also a triage that happens. And by its very nature, triage places people who with more severe illness ahead of others. And that's rightfully so, but the problem is that our system then very often doesn't provide the service for those who have mild symptoms, who are not yet significantly ill. This point was made very salient for me. Sorry, I'm just trying to do something else while I'm talking. But this point was made very salient for me when I first published this book. This was my first time writing anything like this. I've been in the business of leading change and leading services, and I don't consider myself an author. This is just something I wrote from my years of experience. But when it first went up on Amazon, I was like a kid at Christmas. Oh my God, look at this! I wrote this, and it's on Amazon. So it was pretty exciting. And then after a couple of days of it being up, I discovered that people can write reviews of products. And so there was this review of mine there, and that review was scathing. It tore the book apart. And so that devastated me, of course. I took a few days of not looking at it because, all I could think was, oh my God, people will read this and nobody will want to read the book and it won't make any difference in the world, which was its purpose. I waited a week or so, I went back and read it, and then I discovered a nugget right in the middle. And that nugget was actually proof of concept. It was actually endorsement of one of the key principles that I had written about. The note said, Mr. Leader's concepts might work well in a community counseling setting. However, the mandate of the mental health and addiction program in Nova Scotia is to treat the severely and persistently mentally ill. And all I could think was, yeah, you don't get it. You didn't read this closely enough, because a core concept in this book is the fact that if we're seeing the whole public as the client, then a client-centered system, in fact, provides service to people that represents what we would normally think of as early intervention. So people who don't have a diagnosable anything at this point, but they're struggling with some symptoms. Somebody whose sadness is lasting a little too long may not be diagnosable as anything. Somebody whose anxiety is starting to disrupt their lives. Somebody whose thinking is becoming a little more confused, could be using, in this case, early psychosis programs, which we do have in many areas for that early intervention. But for the most part, we don't have those things. And if we started to have more of that early intervention support and counseling, as opposed to just therapy after you're ill, we would end up with a different outcome in terms of rates of illness, because we know that many of the illnesses we're talking about, certainly addictions, many mental illnesses, we know that they are preventable if we intervene earlier. We know the prognosis is better if we intervene earlier. And so we know that if we were to provide those supports that might be as simple as things like skill building for managing sadness, and skill building for managing anxiety, managing stress, those kinds of initiatives could actually have a dramatic impact on the health of our population. But our system's designed around a pathology-oriented model. It waits for pathology, and then it provides that top-down, expert-driven, paternalistic kind of approach, which I'm thankful for those who reach that point, but it's incomplete. It's necessary but not sufficient. It's not really client-centered if it's only serving some of the clients and discriminating against all the others. And in fact, I'll take it a step further and say, in a truly client-centered system, with the whole public being the client in this case, we should be investing in evidence-based mental health promotion activities. And we have some of those. I mean, social and emotional learning, we know that if we implement that as a school-wide program in elementary schools, we know that we will reduce rates of mental illness, addiction, bullying. We'll see increased grades. So are we investing in that in a concerted way? No, it's sporadic around the country is what it is. But if we were client-centered, it wouldn't be sporadic. We would implement that as a systematic and systemic approach. All right, so one of the things when we talk about people being the client, so I've covered that piece of who is the client, but what does it mean to be at the center? So we use this term client-centered, and I know there are variations on that around the country. That you'll see patient-centered, person-centered, person and family-centered, client and family-centered. There are all kinds of varieties. I use the word client for a few reasons that you can read about in my book if you have it. But let's move on to this. To say that something is client-centered, what does that imply? Well, to say somebody is at the center of your life, if you think about if you have children, if you have a spouse or a partner in your life, if you have someone, a key person, if you think about that person being at the center of your life, what does that mean to you? Well, it means that person's needs come before anybody else's. It means that person is the most important person in your life. Okay, so what that really means is that person is your priority. And we misuse the word priority. We use it as if it means important, and it doesn't. It means one thing comes prior to another. One thing comes before another. So when we talk about our organization having priorities, well, it's probably a misuse of the word, because often what it really is just a list of important things. But we haven't ranked them. We don't think about which one is more important than another. So if we have fiscal restraint or fiscal responsibility as one of our priorities, and we have client-centeredness as another one, well, when we're faced with the conflict between those two priorities, similar as we experience sometimes with ethical principles, for instance, competing values, competing pressures. Which one will we choose? Well, what happens now is that we choose whichever one suits us in that situation, because we haven't predetermined that client-centeredness will come before fiscal restraint or fiscal responsibility. A client-centered approach would mean that the client is the priority, or the client comes prior to all other pressures and considerations. Prior to. If we're not doing that, if we're not pre-establishing that priority in that way, then we cannot honestly argue that we are client-centered as a system. We could maybe argue that once somebody is in the care of a nurse or a peer supporter or a psychologist or whoever, we could argue that their care is client-centered in the Rogerian sense, and revolves around their needs and is led by the client's self-determination. We could make that argument, but we can't argue that the organization is client-centered unless we've predetermined that level of priority. So when I've talked with clients, when I've read, media stories, and I speak with a lot of people around this country and hear from a lot of people, their experience of many of our systems is not client-centered. They feel lost. They feel unsure about where they should be going, what they should be doing. They're not really sure if there should be somebody helping to support them at various points. People on the outside of our system in many areas of our country, if they were to use the new version of the phone book, for any of you older folks who remember what that is, but the new version, Google, if they were to use that to try to find us, to try to find help for their addiction or mental health kind of issue, what would they find? Would they find a single number? Would they find multiple organizations, multiple locations, multiple program names, that many of which would not make sense to them? If they were to find that, that would be a problem for them. When we as an organization or as a province or as a network, when we publish very simple information, this is a simple system issue. It's not meant to be the be-all and end-all, but it's a simple example that when people are looking to find us, if they have to try to figure out which number to call, which email, which website to submit a request to, which program name is the one that's right for them, if they have to figure that stuff out, then we're disadvantaging them in a way that we should not be, especially clients in this field. Again, if I'm looking for a knee replacement, or I'm looking for an MRI or something like that, there may be multiple clinics, multiple places I can receive that, and my knees don't stop me from being able to process that information. They don't stop me from feeling comfortable making a call that might be the wrong number. But if a client is dealing with something like an anxiety disorder, is that person going to be comfortable calling a number that might be a wrong number? If somebody's dealing with confused thinking, that might be early psychosis. If somebody's dealing with confusion or delusional kind of thinking, that might be part of a bipolar experience, what are they going to feel? What are they going to experience when they're looking at multiple locations and numbers? Well, they're going to feel confused. It's not going to be something that is comfortable for them. It's not easy for them. So why do we have multiple organizations, networks, multiple numbers within organizations? Why do we have all of that published? Well, we have it that way because it matches our structure. It matches the structure of having multiple organizations. Even though we could have a single navigator kind of system, it matches the structure of our programs. It's convenient for the system to publish things that way because it makes sense to us. And so there's an egocentrism there, and that we assume that it makes sense to other people. But the people we're dealing with, simple things like that, we have to stop taking them for granted. So how do we get at this issue? That's just one example, like I said, but one of the things that we often do, that you'll often see people do, is when they're trying to think in a client-centered way and make decisions, you'll hear them ask this question. So what if you were the client? How do you think this should work? How would you want to be treated? How would you want the program to process you and provide for your needs? Well, when I was leading change in the South Shore of Nova Scotia, I discovered that this question doesn't really get us where we need to get to. It's not personal enough. And so I would ask my leadership team, we'd be talking about an intake process, and I'd say, so, if you were the client, how would you want this to work? the problem is this, that people give intellectual kinds of answers. Because they're sitting in a workplace where their job is to think from a work perspective. And even though you're getting them to reflect on their own lives, their answers are still somewhat academic. So if you asked me this, if you asked me something like, Todd, what would be an acceptable wait time, for, when I show up for an appointment, how long should I have to wait sitting in the waiting room? If you were to ask me that, I'd say, well, I'm pretty patient. I could handle up to about a half hour. But if you were to say to me, Todd, if the client was your daughter, my answer would change. I would say I would want her to be seen on time, period, because there's no reason for anything other than that. Anything other than that is disrespectful and inappropriate. And so if you think about the difference between those two questions in your own life, if you ask yourself what you would want for yourself as a client versus what would you want it to be if it was your mother, your answer probably went from being processed in your head to being processed in your heart. We go to an emotional level when it's somebody we love. I believe this is the magic question. I believe this is the one that can anchor us to starting to conceptualize what it would be like to be a client and what we would want for a client if it was someone we love. So I believe the answer to this is actually the best definition we have of client-centered. I'm not saying that we shouldn't be consulting with clients, because I absolutely believe that first voice is critical. But when you're in meetings, when you're in situations where you don't have access to that first voice, this will get you the closest to it that you can get. So start to think about things that way. And when you do, you start to recognize that from a client's perspective, if we come at it from that perspective, we will have less tolerance for some of the things that we normally consider to be normal in administrative terms. So as leaders in our system, as staff working in the system, we take things for granted. We assume that the way we normally do things is actually acceptable, and as long as we call it client-centered, then it is. Well, how many members of the public would consider it acceptable to wait for many months for an appointment? Well, not very many. People are standing outside the doors waiting to get in. And in our area, some of the doctors in the area where I transformed this program, they used to refer to the mental health program as a castle with a moat around it, because the hardest thing in the world to do was to get in. And so physicians used to put suicidal ideation on referral forms, mainly because it would help people get in the door. It would help to get them across the moat and in the door. Things like wait times matter, and things like wait times aren't just about more money. They're about redesigning the way we do things so that we make better use of the clinical time we have. So, for example, one of the things that we did, of course, when we centralized our intake process, we ended up with our intake workers being able to actually book directly into all clinicians' calendars. The intake workers had total control, and we discovered once we did that, because we had some people at that time who still were using paper calendars of their own, and so there was this privacy thing as if they were in private practice, and that's fairly common across this country, that the clinicians in many of our organizations function more like they're in private practice. They have some selection discretion over which clients they take. They manage their own schedules, and from a public service perspective, that's actually not the best way to do it. So anyway, we centralized that. Intake workers were in control. We standardized the number of sessions per day as a minimum, and we struggle all the time with things like caseloads. What's an appropriate caseload? You can't do that, because we know that some cases take a lot more time and work than others. So the number of cases is not the way to do it. Instead, though, what we can do is standardize the number of hours spent, the number of sessions per week, per day. And so we standardized that to about 4 per day, but we built in time in between them for paperwork, for the kind of administrative stuff that people need to do. And we discovered when we finally could look into everybody's schedules that there were people who were claiming to be busy who were doing 1 or 2 sessions a day. And so that diversity in a public setting is simply unacceptable. In a private practice, you can see one person a day all you want. It's completely your right to do that. In a public sector setting, it's not. And so simply looking at that basic stuff and making sure we're using people the way we should be is a critical piece of this. But the other piece, for instance, around this wait time issue, I mean, do we look at what we do with no-shows and cancellations? Often with no-shows and cancellations, when we have those conversations, people are focused on how do we reduce no-shows and cancellations. That's one approach. Great, do all that you can. But the other question is, what do you do with the time slot that's left when you can't reduce it? Because you're still going to have people who don't show up. You're still going to have people who call an hour or two before or the day before and cancel. So what do you do with that? Well, what we did was empower our intake workers to take control of that and to fit people in even at the last minute if it was possible. So staff would have administrative time booked, for instance. They might have an hour booked the next day, for instance, for just doing paperwork. And somebody calls an hour ahead of time today and says, I can't be here today for my appointment that's in an hour. And the intake staff who would get that message, they would immediately go to people who were waiting for an appointment, who were booked for an appointment much later, like months in advance, and they would call them and say, listen, cancellation just came up. Any chance that you can be here in an hour? So they'd contact people who were local, and so somebody would show up if they could, and if they couldn't fill that slot, what we would do is we'd say to that clinician, the time that you have booked tomorrow for administrative time, I want you to take that in an hour when you were supposed to see John. Do your administrative work during that session, and we're going to book you tomorrow for the time that would have been your administrative time. So, simply shifting things around so that we make the priority fitting clients in and never wasting an hour of clinical time, those kinds of shifts within made a dramatic difference. They dropped our wait time by months. Just that work itself dropped our wait time by months. Looking at how much time people are spending in meetings, there are a ton of those things that we had a 2-hour meeting a week with 15 or 20 clinical staff in one site, for instance. That 2-hour meeting, we cut it down to 1 hour and kept it to focusing on only the stuff that clinical staff really need to be in discussions about, not updates, not basic information that could be sent in an email and read during administrative time. So we cut it in half, and by doing that, we gained about 20 hours a week, 20 sessions a week. That's 80 a month. That's 80 appointments a month that we gained just by taking away 1 hour of a staff meeting. And so, the wait time dropped, again, dramatically with a very simple change, so that it's just about making the meeting times more efficient. It's about focusing on only the stuff that requires clinical staff to be there and requires them to be all together, as opposed to reading something separately, or that could be done in phone calls here and there. And so we made that kind of shift. And the result was we ended up dropping our wait times from 8 months to 1 to 2 months for adults, and from 5 months for adolescents to 1 to 7 days. And it was through these kinds of manipulations where we actually shift and say, well, the priority here is getting clients in. That's the priority. It's not the convenience of staff. It's not efficiency of the organization. It's not about working staff to death. It's none of those things. It's not about going that far. It's just about saying we have a clinical slot. We have a certain amount of clinical time. We're going to use as much of that as possible for actual clinical work. And you can be creative with that, but you've got to challenge some of the traditions as well, the private practice kind of traditions. So let's look at some more examples of what a client-centered system looks like. So those are system issues, as you can see, right? The ones I just talked about, those are system changes. They do not reflect in any way on the quality of clinical staff, the quality of the clinical work being done. They're strictly administrative decisions about the way the system functions, but they make the client's lives better. So, one of the things we're stuck with in our systems is a lot of paperwork. If I polled you right now, I would say you would probably all say that you hate paperwork. Who doesn't? We show up at an appointment at somewhere. It might be a new service provider that we're accessing. It might be a service we've been to before, but we're still stuck filling out forms. We're still stuck answering questions while somebody is sitting there looking at us from behind a computer screen and asking us questions and typing things in. How does that make you feel? Does it make you feel welcome? Well, let's imagine that you're dealing with some type of mental illness. You're already dealing with a lot of potentially marginalization from people in your life. You're dealing with stigma. You're dealing with feelings of inadequacy and low worth and value. You're dealing with anxiety. You know, you're dealing with a lot of things, and somebody's going to sit there and type data in while while asking you questions. It's simply not client-centered. There are other ways to do these kinds of things, and people are far more comfortable with you sitting, jotting notes down while you're talking, and asking you questions that way. People are more comfortable with that than they are with you sitting behind a computer and asking questions. And so the other part of this, though, in terms of paperwork, is that, you know, we get frustrated over the amount of paperwork. We get frustrated over the way questions are asked, you know, that process. Those are not always client-centered. We also get frustrated over things like duplication. You know, ask yourself the simple question: have you ever, while in a particular health service, have you ever had to answer the same question more than once? The answer for most people I ask, when I ask this at a conference, hands go up. Hundreds of hands go up, because it's a normal thing. And that's simply because one part of a system isn't talking with another part of the system behind the scenes. We need to get our crap together around this stuff, and we need to start to actually make sure that the things that we have to do behind the scenes stay behind the scenes. If we've collected the information, figure out a way to have it populate a different data system that we need it in. Figure out a way to have it on paper transferred to somebody else who needs it. But that burden should be ours, not the client's. It shouldn't be their responsibility to populate multiple systems, their responsibility to get information to multiple providers in our system. That's not their job. They're not paid to be there. We are. We are paid for the inconveniences. We are paid to make sure those things are not inconveniencing the client. So are we doing that? Are we eliminating duplication? Are we eliminating questions we ask people that are more for our data collection desires, some of which might be mandated from above us, from government? Fine, but it's still the system dictating that, you know, there are questions that we need answered because we want that data. And I've seen many times where people are sitting around, you know, I've sat around many times designing new software, for instance, new client information systems, or designing a new form. And while sitting around the team that's doing it, people are saying things like, well, what else do we need to know? What other questions do we want to ask? While we're doing this anyway, are there any other questions that would be useful for us to ask? If we're doing that, we're not asking the most important question, which is this: if the client was your father or your brother or your son, what would you want them to be asked? Would you want them to be asked more or less? Would you want them to be asked essential questions or discretionary questions that would be interesting to know? The answer is pretty clear. We're all in the same boat on this one. None of us enjoys that, and we would not want our families being put through that. So again, it's a part of a system that's been designed that is not designed around the needs of the client. We rationalize it. Thank God for Freud, right? He gave us some pretty cool tools like rationalization. And we rationalize the use of those kinds of data collection processes by saying things like, well, we need that in order to make sure that we're serving the needs of the public. We need to know, about trends. We need to know about numbers. And sure, there are some aspects of that we need. But there is no question, if you objectively look at the forms, online or paper, that you use, that you ask people questions from, if you objectively look at that, or give it to someone who's not part of your system to ask that question, you will find things that are not actually necessary. The more of those we eliminate, the more staff time we free up, the more service we can provide because we have more staff time. But more importantly, the less client time we're wasting, the less client experience we are tainting with administrative hoops that we're making them jump through that are not the reason they're there. It is about the client experience. That's what we need to focus on. And that's where we need to go. And so simple things like paperwork can both improve the client experience and improve the efficiency of the organization as what I would consider a secondary outcome. Oh, wait rooms. I love this child's face in this. Anybody like sitting in waiting rooms? These other people, I'm assuming were actors for this particular bit of stock photo work. And I'm pretty sure that most of us don't look that relaxed and not happy in waiting rooms if we're waiting for very long. Why do we have waiting rooms? I discovered this issue one day as I was walking through our building. We had multiple hallways that joined in the center where the waiting room was, and it occurred to me that we have a waiting room for a reason. Every single service in healthcare has a waiting room. That means we're planning for you to wait. It's part of the plan. It's part of the system. We plan for you to wait. What's the reason that we do that? Why in heaven would we need to plan for you to wait? That's simply a scheduling glitch. And the reason we do it in many aspects of healthcare is because we want to book people tight enough together that if by chance somebody doesn't show up, for instance, that we don't end up with a physician or somebody else, some provider, sitting there with nothing to do, with no clients to see, or with unbillable time if it's a fee-for-service kind of approach. So it's meeting the needs of the system to make sure we're not wasting any time, but it's not meeting the needs of the client. Again, I'll go back to my arthritis in my knees. So if I'm going to an orthopedics clinic and they make me wait for a while in the waiting room, I'm sitting there for a half hour. That actually works pretty well for my knees. My knees don't get worse because of that. But I live with depression. I don't know about any of you, but I live with depression. I have for a long, long time. And I can tell you that if I'm in an acute phase of depression and I were to go to a service whose job it is to help alleviate that in some way, and I'm made to wait, I'll tell you what the message is for me. I know exactly how I would interpret that if I was in an acute phase. I would interpret that as me being not important to be seen on time, not important enough to be seen on time. That the clinician's time is more important than mine. That whatever the clinician is doing right now is more important than whatever I need to do when I leave here. And that it's inappropriate for the clinicians to be inconvenienced in terms of taking up extra time, but it's not inappropriate or unimportant. It's not inappropriate or unacceptable for my time to be wasted sitting here. That's exactly what would go through my mind. Imagine if I had social anxiety and you're making me sit in a public area with strangers. We're actually causing harm to the very illness that we're supposed to be helping. It's not that we're allowing people to experience harm. We're causing it. It is an active, though unintentional, cause of harm. It's an ethical issue for the organizations. And again, it's just a simple example. There are hundreds of these in our programs. We just need to think about walking our way through the client experience and ask ourselves the question, is this what we would want it to be if it was, if it was my daughter, if it was my wife? Is this the way I would want it to be? Is this really about my family member? Is it about them, or is it about the system? So the most authoritarian thing I ever did in my career was when I thought about this waiting room thing, which again strikes you maybe as a trivial thing. When I thought about that, I realized that this is an easy fix. So I went back to my office. I sent an email to everybody in the building saying, as of tomorrow, if a client arrives on time, the client will be seen on time. And so it took 2 or 3 days for people to adjust to that. But by the end of that week, we didn't have a waiting room anymore. We had an extra hallway. The chairs were empty. People would show up. They'd go up to the desk and register. They'd maybe get their bum in a seat for a minute, and then somebody would be there to get them. It was a very tiny change, but the experience of the clients was changed dramatically because they no longer had to anticipate waiting. They could simply show up on time and be seen on time. The system was meeting its agreement. The system was meeting its part of the contract. Because an appointment is a contract. It's a two-way agreement. If you show up at 1 o'clock, I will see you at 1 o'clock. That's the agreement. It's not just if you show up at 1 o'clock, we'll see you whenever. So we were starting to meet our part of that. So again, that's another kind of minor change. But as I said, the expression on the child in this picture, I believe, captures the feeling of many of our clients, especially those dealing with addiction and mental health problems. And this waiting and exacerbating people's symptoms because of the nature of their illness, I equate that to having an orthopedics clinic on the 3rd floor of a building with no elevator. The actual act of getting into the treatment will actually cause more harm to the illness that it's supposed to be helping. So these are system kinds of issues, you know, and there are more. I mean, you can go through this and find, and I won't go on too much longer, but you can go through your own system and find tons of examples. Like, you know, when somebody calls your service, are they getting an automated machine? Because everybody hates those. We know that. I mean, we all hate them. Why wouldn't they? So a menu tree. You're dealing with somebody with early psychotic symptoms, and they have to figure out which number to push. You're dealing with somebody who has anxiety, and they have to actually have the courage to push a button. So again, those kinds of things. Is a real person answering the phone? Is it a friendly person, or is it somebody who sounds like a clerk who just wants to enter data and go home? Those are things we can change.
Todd,
It is.
Todd,
Yes.
I'm so sorry. It's Regina. Sorry to interrupt you. Well, we're just getting some messages asking if we could see the kid in the waiting room, if that's possible. Just the slides, we can't see them right now.
You can't. Have you been not seeing the slides all along?
No, we have not. No.
Oh.
That's okay. It's okay.
Why is that? Like, oh my God. Okay. Well, so what have you been looking at? My ugly face? I'm so sorry, folks. I didn't mean to torture you. I'm talking about client-centered, and I'm torturing you with just a picture of me. So
just hit the screen share button at the bottom.
Yeah, it's not here, actually. That's the problem I have.
Oh.
Is that it's not here. It's not showing up anywhere on my... That's why I thought it was...
Right. So,
okay,
Jen, Todd's a host.
Todd is a panelist.
Did that change? Sorry. Can you...
No, not yet. No.
Oh, heavens. Okay, just 1 minute. Just bear with me for 1 minute here.
Yeah, take your time. It's okay. We're getting some good feedback. We have a question that we'll just hold to the end. And then James is just adding that we completely concur with the need for efficient paperwork. So I think what you're saying is really resonating with people. So you're doing a great job, Todd. Thank you.
Okay. Now tell me if you can see that.
Yeah, beautiful. Thank you.
Okay. All right. So let me just do this for a minute, because I had all these lovely pictures that, so this is, I'm just going to go back. I'm not going to rediscuss these things, but just kind of show this is the key that I was talking about earlier. This is the question we need to be asking to actually get at this client-centered concept. And these were just lovely pictures. This guy really enjoys his paperwork, probably the same as most of us do. I think I've looked like that, except way older many times. And this is the child I'm talking about. So this is the face that I believe represents the experience of most of our clients if they're made to wait more than 5 minutes in our areas. So we need to somehow get past that, so we're not causing that experience. Okay, so you know, this shift that we're talking about, the shift that I'm trying to describe, is a shift from what we currently have, which is in most of our areas. If you think about the decisions that are made by management, by administration, and again, just to be clear, I'm not blaming administration for our current status, because when we adopt a position, when any of us are hired into a position, we're given a position description, we're told what we should be paying attention to. And if you're in management, your job is to manage the system. But we need to shift that so that our focus and our criteria for making decisions doesn't always revolve around things like budgets. And, you know, the phrase I have learned to love to hate is, you know, finding efficiencies in the system. You know, I'm sure that you've all heard that before. And liability and risk. And it's not risk to clients. It's actually, you know, how do we reduce the risk of us getting sued? And, you know, so that's a huge one. Media, our public relations, the spin we put on things, the need for the organization to look good. But, you know, often it's phony. It's not because we're actually doing what the clients need. It's just that we want to make it look that way. And so adding more services, more money and more services becomes a real dominant kind of a theme. And so media relations, labor management, you know, our collective agreements, many of our collective agreements in unionized environments, they are designed, of course, as they're supposed to be. They're designed to meet the needs of the employees and to meet some of the needs of the employers. And so there is that mix, but there's very little in there that's actually explicitly talking about the prioritization of the client experience. So why don't we start to renegotiate our collective agreements so that we try to get unions and management on the same side to say, well, look, we're going to look out for the needs of the members and of the organization, but let's start to put in some prioritization where we say that, for instance, if you're going to hire a receptionist who's going to be the first greeter of these people who are experiencing serious struggles and experiencing shame and all the things that we all experience with mental illness, if you're going to hire somebody to be the one who answers the phone or the one who greets you when you come in as a client, why can't we hire that person for having a compassionate and warm and friendly personality? Try to get that one into a collective agreement. Doesn't work that way. The way it works is, people of approximately equal qualifications, seniority will win. Well, that's not client-centered. Sorry. That is completely union-centered. It's not even employee-centered. It's union-centered. And again, that's simply not the right criteria we should be using. What we should be doing is prioritizing things like, how do clients get in? How quickly and easily do they get in? Can we make it convenient for them? When we did our transformation, we walked through the path of a client from the time that they Googled for a number to the time that they got into care somehow. That was a big focus of ours. And what we were looking for was efficiencies, but efficiencies for the client, not efficiencies for the system, making it convenient and efficient for the client. But in doing so, we eliminated a ton of excessive use of our own resources. We streamlined our own process. That's what brought down our wait times, made us more efficient, but it wasn't from looking for efficiencies for us. Streamline the process, get rid of some bureaucracy, get rid of some paperwork, allow the client to determine what he or she wants to do. I mean, how many organizations out there, I'm not actually asking, it's kind of a rhetorical question for you to think about, but how many organizations are still doing a standard comprehensive assessment of every single person that walks in the door before we start doing anything that the client actually is there to talk about? Well, I understand screening for risk. I understand brief screening for risk, not comprehensive assessment. But if we're assessing everybody for pretty much everything, and we've got a long history of doing these assessments that can take anywhere from 45 minutes to 2 or 3 hours. Well, if I was going to the emergency department with a broken leg, would you expect them to do a full body MRI, blood work with a full panel, bring in a dermatologist to check your skin? I mean, would we be doing those things? Absolutely not. You're not going to do an EKG. You're not going to do a liver function test. Why not? Well, because that's absurd. That's why. It's absurd. I'm there for a broken leg. Fix the leg. Check the leg. Hey, and here's this. If I go unconscious while I'm there or I turn yellow, well, then you should probably check my heart or my blood work or my liver functions. But if I don't, then let's just stick to what I came for help with. Ask me what I want, what I need. Work on that. And if something else comes up or is indicated during that, then let's explore that. So if I come to talk about depression, but in the context of my discussions with you, you're hearing signs of hallucinations or delusions, of course you're going to explore those. But if you don't, let's just talk about what I want to talk about. It's called self-determination. It's called eliminating paternalism. This is an ethics issue again. Right? Putting the client first means, and Carl Rogers had this wrapped up a long, long time ago. This is not new. I'm not inventing something new here. But, getting to the point where we truly individualize what we provide to each client, where we truly, I'm going to use this term loosely, individualize the types of treatment we provide across various kinds of populations that have distinct differences from others. Cultural kinds of differences. We need to be able to adapt and treat each person in a way that matches what that person needs in the way that that person needs, and eliminate all the bureaucratic, administrative standardization even. That I hate that word. Standardization is the enemy of client-centeredness. I'm not saying we shouldn't have standards, minimum standards, like every area of your province needs to have at least this type of service available, and I get that, but standardization is about making things rigid. That's statements like, everybody has to administer this assessment to every client that comes in. That's standardization. And it assumes one size fits all. And one size fits all doesn't exist in our world, not even in t-shirts. It doesn't exist as a concept. It's just a phrase, but it means nothing because there's no such thing as sameness across multiple people. And if we think there is, then we're not listening. You know, someone once said, I was at an indigenous people's conference once, and somebody once said, and I guess maybe you've heard it in other places, but, you know, there's a reason we have two of these and one of these. And that's so that we listen more than we talk, because it's a more important skill. So if we start to listen to our clients, ask them what it is they want, what it is they need, listen and customize, and, you know, get rid of the stuff they don't want. Nobody shows up at your service to fill out papers. Nobody shows up at your service to have somebody sit behind a computer and act like a robot. Nobody shows up at your service to sit around in your room instead of their room at home. You know, these are really simple things, right? And so much of it can be changed without any dramatic kinds of efforts. It doesn't cost money to make these changes. And it can gain you huge political favor and public favor. So if you're looking at it even from a selfish organizational perspective, I'll tell you a little anecdote that I'll end with. When we were going through this transformation, our entire focus was on what's best for the client. And so we changed anything and everything we could. If a client came in with a complaint, we would sit with them, we'd listen to it, and we would book them for a second meeting a few weeks away so that they would hold us accountable for making changes. We followed this process constantly. And we had had as much negative media coverage as anyone else had ever had, any other organization. We were in the paper as much as everybody else is across this country, with stories of everything from wait lists to disrespectful paternalism. And anyway, by the time we finished this transformation, we then entered into almost a 3-year period where we had not a single negative story in our media about our program. Not one. And we had between 15 and 20 positive stories in our local and our provincial and even national media, national television coverage even. And all we did was designed it to be best for the client from a system perspective, and then make the assumption, have trust and faith that the clinical people, the support people are doing client-centered work once the client is in their hands. We need to think beyond just that clinical work. We need to recognize that the system is responsible for a great deal of the client experience, being positive or being negative, regardless of the skill of the clinicians. And all of this falls to leadership teams. It falls to managers, supervisors, directors, vice presidents, CEOs to set the culture, to say, we're going to put the people first, and we're going to stop just talking about it. We're going to actually start to make this change, because it is time. It's time for us to stop talking just about adding more stuff and start talking about shifting what is the focus of our entire organization. What comes before other things? And, you know, we need to recognize in the end, and this became the title of my book because I started to say it to staff, you know, when we'd start to generate client-centered ideas, and somebody would say, you know, yeah, but we can't do that because it'll cost us more money. And yeah, but, you know, John won't want to work evenings to offer appointments. He's used to working Monday to Friday days. And yeah, but the union this, and yeah, so we got lots of yeah, buts. And my answer was, it's not about us. It's not about us. We are paid to make it about the clients. Whether you're a CEO or a vice president or a peer supporter or a psychologist or a social worker, doesn't matter. You are paid to make everything you do during those paid hours, everything you do, about the client. It's not about us. And I'll stop there.
Well, Todd, if we had like a round of applause, I think we would just start with that. Thank you very much. I think you've given us some ideas to move forward with. I think you've challenged us in some ways, which is always the sign of a good speaker who just kind of puts you outside your comfort zone a little bit. So thank you very, very much. What I'll do is try to just capture some of the questions and that have just come in as we were chatting, and then I'm sure other questions will come in as well. But just to begin at the beginning, one person had asked about if you were familiar with the OCAN, and I guess the question was, so I always know that that's sort of it's an assessment tool used primarily in Ontario, I think. But the question was, do I fill that out at the time, or the dilemma being, what is the best use of clinical time? So I could maybe do it in the room with the person, or should I do it on the computer, or do I do it afterwards? And I think you spoke to us that really about the value of just that personal interaction and not having a structure in the middle, often a computer, as we're working with people. So that was our first question that you might want to respond to.
Sure, and that's you've captured it, Regina. It is, for me, it's thinking about it from the client perspective. If your brother was the client, would you want someone typing it into a computer while having the conversation? No, because you're not building a relationship there, and without building a relationship, no good is going to come to this client. And that is the fundamental piece of what we do, is building that rapport, that trust, that comfort. And so, what causes comfort to happen? Well, asking questions. People will get used to that. That's fine, even though they might not like it. They expect that part. We have to ask questions as part of our conversation. But if you're just jotting notes on a clipboard or a pad or something like that, that is far less intrusive. It obstructs the process far less than typing it, or even than trying to fill it into a form. Because if you're trying to fill it into a form, you're looking down at the paper far more than you would if it's just a notepad. Far more, because you're trying to make sure you're checking it in the right box and you're filling it in small enough to fit in the box. If you're doing that, it's, again, the least intrusive thing is simply a notepad. Get used to what the questions are. Have a conversation instead of a checklist of questions. Have a conversation and jot down notes and book time after the session so that you sit down and do that transfer into either paper or online. And if that's not there, then restructure the scheduling so that it allows for that, because the client experience will be more positive.
So I think that's a pretty direct answer. Thank you very much. We also had some comments about just the dilemma sometimes of trying to keep a system happy in terms of the requirements that we have from that, and then balancing on the other part, just what you've said, just that client-centered care or client-centered support. And so James just beautifully, as he does, just talks very eloquently about just balancing the needs of the system versus the needs of our participants, with an authority that seems so detached sometimes from everyday stressors and realities of those who we journey with. So
yeah, that is the ongoing challenge in trying to make this transition. That is the fundamental the foundational kind of challenge, because people need to keep things like, I don't know, a paycheck. People like to keep their jobs, and so you can't just start running around screaming these kinds of things and not tolerating the administrative stuff that is part of the system. But how do we challenge it is the question. And for me, it's less about challenging what we do and more about starting to frame what we could do as the sort of the target or the vision. People aren't threatened by a vision so much as they're threatened by a challenge to what they do now. So the trick is to get people starting to feel this change. So if you're sitting around a staff meeting with your manager and you're trying to figure out how to handle a particular situation, ask that question. Ask the question, well, okay, so can we talk about it from a client perspective? If the client was your son, how would you want this part to work? Let's at least explore that and see if we can get closer to that. That's not really a threatening or intimidating way to raise the question. And if it is, if you've got a manager who is threatened or intimidated by that, then I'm really sorry for you, because you've got a very insecure leader in that situation, and somebody who probably shouldn't be in management, frankly. So we need to start to, and that maybe becomes one of those situations where you have to accept the things you cannot change. and simply go about your business and do the best you can within your own authority. But if you've got reasonable leaders, secure leaders in your system who are okay with having people suggest new ways of doing things, use that question as the way of getting people thinking from an emotional perspective and an empathic perspective, and you may get a little bit further with that. You will always have the system keeping constraints on what you can do. None of our systems has unlimited money, for instance,
Right.
and there are things called labor laws, and there are things we need to do. We do have to look out for those things, but how much of that can we carve off or water down? Can we push the line just as far as we can, instead of, some of you probably have experience with managers or leaders who will always push back to keep people from coming even close to the line. And we need to not accept that. If we can at all get away with it, we need to start to say, well, let's push closer to that line.
Mm-hmm. Mm-hmm. So Todd, I'm going to put two things together. We had a question for where did you do this work? I think the question was, what specific system did you engage in this transformation? And then another person, Ken, notes that in mental health there are extended leaves, mandated medication schedules, certifications, warrants, arrests, which are all completely antithetical, a word I can't say very well, to the spirit of client-centered care. How do we reconcile? So I guess...
Yeah, well, some of that is this issue of recognizing the things we can and can't control. Like I said, there are always going to be those limits, and that's okay. But I guess the other thing I'd suggest to help get at this is, I was fortunate to do this. It was in the South Shore of Nova Scotia that I was fortunate enough to lead this team, and I was fortunate enough to have possibly the most important asset you could have, and that is I had bosses who supported the idea of doing what's best for the clients. And I know that every one of your bosses will use those words. And that's, and some of you out there, I know that's the terminology everybody uses. You will not find a health organization in this country that doesn't have a plaque or a poster somewhere on their wall that uses some client-centered kind of phrase. Everyone claims to be, but the question is, do you have secure leaders who are really okay with their normal way of doing things being changed, being challenged? I had that. I had a vice president and a CEO who, when the the resistance started, and because there will always be some of that when you push this kind of fundamental change. I mean, we're talking here about pushing past a traditional pathology-oriented model into a client-centered recovery kind of approach. And that will always get pushback. And when that started, my CEO and vice president pulled me into a meeting and said, here's what's happening, and the shit's hitting the fan. And they said, so the CEO said, tell me, if we support you in this to keep going, will it actually change the client experience and reduce the wait times and improve access? And I said, yes, or I'll leave my job. And they said, okay, we've got your back. From that point forward, I didn't have to worry, because they understood what was the priority. They accepted that our job is to do what's best for the clients, and they were willing to accept that some people, who perhaps, who are more dogmatic in their thinking or less secure professionally, they were going to challenge it, and that's fine. Let them be mad, let them leave. You don't want to be on this bus, this is where it's going, but don't stand in front of it, because we're going there. And so if you can get your senior leaders to really get this concept, if you can get them to buy into this as a real concept, not as a PR exercise, that's where the real secret is, because then they will help you push those lines. You do have to deal with things like court orders, and there's a ton of that legal stuff that does constrain us. But if it's not mandatory in that way, then there is discretion. The question is, who has that discretion, and can you influence them to understand and buy into this concept? And buying my book and giving it to them might help.
So maybe this leads into the next thought, where Jody just says, what's the solution for some treatment programs who often exclude people, so that if they don't fit into the box of what the particular organizational mandate is, so programs don't work for them and we don't change it to work for them, we kick them out instead, I guess.
Yeah.
What might be the solution?
Sure. Well, my early history was in the addictions field, and the addictions field is known for that. In its history, in fact, is exceptionally rigid around a disease model, an abstinence-oriented model, and so we've had 28-day programs. We've had all these kind of models that, if you're not ready to say, yeah, I'm an addict and I'm going to follow this particular approach, then you're deemed. In fact, I'm going to quote, you're deemed to be not ready for treatment. That phrase always pissed me off because it makes no sense whatsoever to say that. It's that the program is not ready for that client. And so, we need to start to look at that issue. So we have lots of programs whose official mandates or paradigms, like that kind of abstinence-oriented model, for instance, their paradigms don't allow for various types of people, types of problems to fit in, and so we expect everybody to change. Part in some situations, we can adjust our programs to be more flexible. First of all, we can get so that, I don't know, if somebody has a slip or a relapse in a detox unit, hey, how about if we don't kick them out for having the symptoms of their illness? Because that's what we're doing in those situations, right? Or somebody is in a psychiatric unit and they display behavior that is so disrespectful or aggressive or something like that they end up being kicked out. I've seen that happen. Those are the symptoms of the illness we're supposed to treat. That's like me having diabetes and going to a diabetic clinic, and because my A1C is high, they refuse me service. That's what that would be like. Or because my knees are sore, they won't replace them. I mean, we're so missing the boat. So we need to start to challenge those things on ethical grounds for our organizations. But then let me go a step further and say that sometimes the issue is that we have organizations that, for perhaps legal reasons or for other firm reasons we can't bend, have a limit to their scope, a limit to their mandate. You may have a peer support organization, for instance, and a peer support organization, if it is strictly peers who don't necessarily carry professional designations or something, well, there's a scope limitation there, right? It's an essential service, but there's a scope limit in that they can't be doing psychotherapy or prescribing medication. So does that mean those clients don't access those services? Well, how about partnerships between organizations?
Yeah, and I think you're helping us think about like larger systems. So having an influence in some other larger systems. So if one organization can't provide this support, that there's others out there that perhaps can.
Sure. I mean, and you'll find professional services as well, professional therapeutic kinds of services that cannot provide the value that peer support organizations can provide. So can they link together in a formal kind of way? And, I wrote a chapter about that kind of interorganizational, interdepartmental collaboration and mergers and integrations, that concept as well. And we miss so many of the things that make that stuff work.
Yeah, and I think it's having that larger systems perspective, isn't it? Just being able to integrate those. Yeah,
absolutely. And from the client perspective, you don't want to recognize that there are different programs, different organizations. You want to walk in one door and have somebody hold your hand through all of the steps
and experience that, right?
So can you do that? That's the question. And how can you do that? And who do you need to engage? And what methods cause good collaboration to work? And I have a workshop on that.
So Adina says, great presentation, relevant and clear. I like the idea of early intervention. She asks, how do you balance capacity factor when we have limited number of hours in a day for the clinician to address both mild symptoms and severe? Is it mostly groups? So that's from Adina.
Well, I would say groups are certainly a good option. Absolutely, right? For some people, for some types of issues, for some people, we know that females are more likely to be comfortable in groups than males. We know that for some kinds of disorders or symptomatology, people are going to be more or less comfortable. So, as long as it's optional for people, groups can be a gain in efficiency and provide a kind of experience that some people actually would prefer. So again, coming at it from that client perspective, how much flexibility do you give them in terms of self-determination? And if as long as that's there, then groups can be great. Otherwise, a caution that I throw out is don't interpret what I'm saying about efficiency or about scheduling of clinical time. Don't interpret it as me saying we need to work our clinical staff harder, because that is absolutely not my message here. But we need to make sure that what we're using our clinical staff for is it's mostly the stuff that they're actually paid to do and that they're trained to do.
Within the skill set. Right.
Yes, absolutely. I mean, look around your workplaces and find out and look at how many people are sitting on various committees, internal and external, community partnerships, and are they the right people? Are we, should there be management staff instead of like sort of non-clinical staff representing the organization at some of those? That's the question I always ask, and I believe that the clinical staff are the ones who need. When I say clinical, sorry, I mean anybody who's providing direct client service. I don't mean it has to be medical or something else.
Yeah.
So. But really protecting the time of those who provide the direct service, that should be the top priority in terms of staff usage. Protecting management time, not important, and that's my world. So I'm, that I say that knowing what it's like to be overrun as a manager. But the clinical time is why we exist. So build in some kind of process with minimum numbers of sessions, numbers of hours per day, per week. Reduce the external use, outside of clinical work of all those staff, and you're going to reach your maximum. And that's when and if you've done that and everybody is being kind of using their clinical time to capacity, and if you can look at everyone's schedules and see that they're not spending time at meetings and committees and doing other things more than they need to, then you can say we need more funding. Then you could say we need more of what we're doing now. But so many organizations look for more money if you truly look at what the clinical staff are being used for, there is actually more capacity there. It's not that there's more hours in the day, but there are things that are non-clinical that probably could be handed to someone else or dropped in favor of seeing another client.
Direct service. Yeah. So we have a final question at the moment anyways. It asks, are you aware of any initiatives taking place to encourage engaging psychiatry in the client-centered approach?
I'm not aware of any initiatives in this regard. Certainly in our area, psychiatry was engaged in this process, some more than others, and it will vary, right? The downside of this, I mean, I don't know, I don't have any magic answers on this, except I do believe that the less any professional is set in their ways in a power structure, because we have a power hierarchy in these systems, right? And psychiatry is at the top generally, and then we have psychology and social work and counselors and peer supporters. There is this hierarchy that sadly totally misrepresents the value of all of our types of service providers. But the more someone is entrenched, the longer they've been entrenched in a system that feeds particular professions power, as opposed to obligation to collaborate, obligation to function as equals, the longer they've been there, the harder they'll be to change. And the less they will want to give up the traditional, paternalistic, expert-driven kind of approach. And I think psychiatry as a profession has that as a risk. Having said that, I've come across many psychiatrists who they live right where we're talking right now. This is how they function. I think it's an individual issue, but I think anybody that has any contact with the profession in a formal way, I think this would be a valuable topic to start to raise with the professional associations, with the associations of psychiatrists and with the Canadian Psychological Association and CMA, and the more of that we do, the more we start to influence them as professions, and then work to grab people into this tent one at a time.
So I was just curious about your last comment there in terms of tent. So as I listened to the presentation, it made me think of a lot of the work that we've been doing here in Vancouver Coastal Health area, thinking about like lean systems. I'm sure you're familiar with those ideas, but it's like it has this overlay of client-centeredness around a lean system that it really resonates with me in a more positive way. But it seems like that's the purpose. That's the reason that we do these things around leanness, which I think can really help. But
Yeah, and just one last comment on that, Regina, is we had one of our leadership team members who had done training in Lean, actually, and so knew this stuff inside out. And as we had been going through this process, her reflection on the two things was that what we're doing is Lean,
Yes.
except the difference is that Lean is focused on outcomes or products of the organization, whereas the focus here is on the client experience as opposed to just how many widgets can we produce and how low the cost can be.
Yeah.
And so that's the difference.
I'm very curious that through this whole presentation, you haven't really talked about recovery, because I think when I think about client-centeredness, and I'm sure that's very purposeful, you're a clever man, so I'm sure, that there's a good reason for that. But to me, it kind of resonates with a recovery-oriented system as well. So.
All I'm going to say to that is absolutely, I agree. That's it. And for me, that's a given. Yes. That's the thing. And I think part of the shift we have to make that will enable us to do this work that I'm talking about is a shift of paradigm from a system-oriented or an expert-driven, pathology-driven kind of model to a recovery model that is really about helping a client on his or her path and providing whatever supports are needed for that individual to live a good life, whatever that means to that person. It's not about, you're ill or you're sick, you're ill or you're better at this point. It's just, how do we help people on their path, for their sake and just to whatever extent they want and whatever ways they want. That's recovery, and that's client-centered, both, right? So I'm with you.
Cool. I'm with you too. I feel like this is kind of a private interview. I apologize. I hope that people just feel free to keep coming with the questions.
Well, that's all right. It's not about them, Regina.
Oh dear. Jen asks, can you clarify what you mean by Lean? And I guess when I talk about that, is just systems, sometimes they look at how they can trim their own ways of doing things such that their outcomes can be different. So meaning that how are we spending our money, how are we spending our time? So I heard Todd talk a lot about how are we using people with the skill set in the best possible way. So that's really what Lean is. It's looking at how can we trim the excess, how can we reuse our resources in a way that better meets the ideas of the organization. Todd, I'm sure you have things.
No, that's fine. And there's a lot about that online as well, right? I haven't done Lean training. I'm familiar with it, but I haven't done Lean training, but there's a lot of it online if anybody wants to look that up. Yeah,
for sure. I just took some notes too while you were speaking, and I love this idea of priority, and I'm going to play with that a little bit more, but that was very, very helpful. So I'm an occupational therapist by trade, and as a profession, we talk a lot about client-centered interventions and client-centered approaches. So I do like that idea about priority. And I just wanted to play some more, not online right now, but sometimes it's not that exclusive. And I think that's where you're coming from, that you can meet behavioral needs and you can meet systems needs, and it's not easy to do. And I think that's what a lot of comments are asking as well, just trying to resolve that dilemma sometimes about meeting both of those.
Sure.
Sometimes apparently competing requirements.
Sure, and like I say, sometimes those competing requirements, I mean, the answer is dictated for you and you have no choice. Mm-hmm. But the question always is, can we adjust? Is this a situation where we can actually change a little bit of the system instead of a little bit of the client? Mm-hmm. And I think one decision at a time, one situation at a time, continuing to look for even baby steps. Is there something about the system that we can change instead of making the square client fit into the round system? Can we start to carve that system a little bit more square every day, just a tiny bit? Mm-hmm. Mm-hmm. That's what we did. I mean, it was a ton of, 1,000 baby steps and 10 or 15 huge jumps to the moon. That's what we did, was the combination of both. But so, don't be intimidated by it and think, well, we can't do anything about it. And, I just, maybe this is an end point, but on my arm, I got my first tattoo. Well, it's my second one actually, but just in December. And it's a quote by Margaret Mead that many of you probably are familiar with, which is, never doubt that a small group of committed citizens can change the world. Indeed, it's the only thing that ever has. And, I've taught 168 courses at St. Mary's University, 10,000 students over 28 years. And I've ended every single course with that quote, because I firmly believe this. And for people on this webinar, who are feeling somewhat powerless to make these kinds of changes, because, how do we meet the client's needs when the system is also demanding this and that? And well, I think it's just start to say it out loud. Start to ask this question about client-centeredness. Start to promote thinking about it, because somebody else will hear you and say, yeah, that makes sense. I wonder if we can try that. And someone else will say, yeah, that makes sense. The next thing you know, you've got a 1 million man march, or you've got women voting in Canada, or you've got, that this is the way change happens. So become one of those voices in your workplace, in your community. Become one of those voices that starts that snowball building, and change will come.
We have another minute or so, and I'm just wondering, so having engaged in some systems transformations over my career, one of the things I think about as I'm an older lady now is thinking that how do we sustain the change? So sometimes we make massive leaps forward, as you've just said. Well, I've experienced too that sometimes we roll back a little bit as well in our systems. And I'm just wondering if you have final words of wisdom because I know we have a number of managers online who might just like to hear the response to that.
Sure. Yeah. That regression back to the mean system, as opposed to back to the mean. That regression is, I think, it is normal, and it's normal generally in systems, right? Systems themselves, when you disrupt homeostasis, systems themselves want to gravitate back to that normal that they know. And so how do we resist that? It's like relapse prevention, only at a system level, right? And I think the secret to that, in my experience, is as you make changes, find ways to build that change into the infrastructure in some way. So for example, building new language, as you change a procedure or a process, build new language into the job description for that particular position, especially in management and leadership positions. Start to find ways to change the language, to change the statements of priority in those job descriptions. Even make statements that you'll see, like some codes of ethics in some of our professions. Some codes of ethics do a really good job of addressing the fact that we will always come across competing values. Competing pressures. That's the nature of ethics, And so even within job descriptions, making statements about those can help to secure this philosophical shift, because that's what this is. If you shift the paradigm and can secure that, the day-to-day decisions will be made according to these principles on an ongoing basis. So putting in statements that say, in this position as a manager or as a director or a CEO, you're going to come across these competing pressures between, meeting budget and meeting the needs of the population or the clients. And so here's the way that decision should be made. To the greatest extent possible, you first meet the needs of the clients by adjusting and changing the system. And then you only stop when you simply have no choice, because there are black and white barriers there from a system perspective.
A bit of an algorithm.
Of sorts, yes. It's just kind of saying, but first meet this need to the greatest extent possible, even compromising the system, and then meet the system needs, if you reach that line, that point of no return. But if we don't state that, then people are left to make their own ethical judgments about these things. And people trained in administration, of course, often will say, well, of course the budget has to come first.
Right.
And well, fine, but that doesn't mean you can't play with it, and mold it differently. And so I think building things into infrastructures like that, changing forms so that they're permanent, get rid of stuff on forms, change the practice of your staff so that when they're mentoring or training a new staff person that comes in, they're modeling things like interviewing with a notepad instead of a computer. And so you build in the sustainability there. I think
the little devil inside me can't help thinking that over time, I wonder as we work with youth, if that will be, I think, I totally agree that the personal connection is so essential. But I wonder too, if there'll be some cultural shifts around that over time as well. Just curious.
In terms of technology and methods of communicating, I firmly believe you're right on that. And I think that's fine, because if that's their preferred method of communication, then it's client-centered, isn't it?
And that's what it's about.
Yeah, so, but if someone's serving an old guy like me, then I'd rather a conversation. And so again, client-centered means adapting to whatever the needs of the population is that you're serving.
Yeah. So I think this is a great summative comment here. This person says, it also seems like transformation looks like not relying on the system so much. And then the person asks, what other ways can we address mental health, substance use issues and challenges within a community? So I like really what you're saying, because it's a community of individuals that we're relying on to sustain change. But that's the last question.
Well, I think, and I'm a huge fan of community partnerships, community networks. There's so much capacity that we can be using, and in many areas we are. But I think we start with valuing the contribution that community, volunteer organizations, that peer support organizations, that might be small community-based NGOs, start to value those contributions, because for many people, that's all they need. They don't need the more intensive, professionalized, paternalistic stuff. They just need someone to talk to who cares and who uses these things more than this thing. And so, I think it's just building this philosophical approach to the client coming first, and building that at all levels, and building partnerships that support that concept. Where the partnerships are not all about drawing lines for our turf in the sand to say, well, this is our job, don't you step over it. And no, it's about actually brushing that line away in the sand and saying, we're going to work together and do what's best for the client who's in between us. And so there's so much capacity there in partnerships that we just have to learn to do it right. And so many of our organizations don't do it right. They ignore what we know about intergroup relations in social psychology. They ignore that. And that's the stuff that will make a partnership functional or dysfunctional. And that's the stuff, like as I said, I developed a workshop about a year ago about that specifically, and have delivered that a few places. And it makes a huge difference in the functionality of partnerships. So.
Well, you're clearly a multi-talented man, and you may not have had the chance to think and respond and everything and see all these great comments that are people saying thank you for just the authentic, honest presentation, and for the inspiring sharing. So just please just accept our thanks and our appreciation for a great session. Thank you.
Well, you're welcome, and like it or not, you when you get me, you get whatever I think. Unfettered. So, yeah.
Thank you kindly. So I know people, it's lunchtime here, not in Halifax, but it's lunchtime at 12:02. So thank you everybody for staying on the line with us. Thank you.
Thank you all. And my book, if anybody's interested in it, it's on Amazon. It's on Indigo Chapters, or my own website. Any information, anybody looking to contact me for anything, workshops or speaking or book or whatever, www.leader-development.ca. or it's notaboutus.ca. So that's a simple one. It's notaboutus.ca.
Perfect. Well, thanks again. Happy rest of the day to everybody. Thanks a lot.
Thanks.
Bye for now.
Bye.
Thank you. Bye.